All right, so we're going to be going over all the protocol updates for 2024. We are constantly updating our protocols. I'm sure this will not be the only time that we update protocols for this upcoming year. So please take some notes, reach out if you have any questions, and let's dive right into it. So here are some of the major topics that we're going to be covering today. These are not all the changes that we made, so please go to your protocol app, go to reference chart, go to the change log. You can kind of see everything that was officially updated, and then you can also go back and look at everything that was updated the last couple months. You guys will have to take a protocol test, so it would be important for you to kind of make sure that you're up to date with everything that's been changed. All right, so we're going to review the cardiac arrest changes that are upcoming. We're going to implement a lot of these through on-shift training. We won't hit everybody, so it is going to be important for every paramedic to review these changes. The goal is to hit as many full-time paramedics as we can, and then obviously get all the supervisors on the same page because they will be the ones that are going to be at all these cardiac arrests. So some of the big changes are going to be involved with equipment. So we really want you guys to focus on bringing in the essential equipment. Some people are very efficient at putting everything on the stretcher and bringing the stretcher in, but I think for the most part, it is going to be a lot quicker for us to just take the equipment that's needed, go straight into the house, and allow the engine to bring in the Lucas and the stretcher. We really would like to have our pad placement change from what it normally is to an anterior-posterior approach. This is based off of research. Research has shown, and we'll go over some of those research articles in a little bit, that anterior-posterior pad placement has done a better job at getting patients out of shockable rhythms. Speaking of shockable rhythms, we're not going to be recommending the use of epi anymore for patients who are in VFib or VTAC. The reason why that is because epi is actually a rhythmogenic medication, meaning that your heart is irritable. That's why it's in VFib or VTAC, and giving somebody epi might make that heart more irritable and stress it out more. The best thing that you can do in those situations is obviously the basics: high quality CPR, early defibrillation, and then giving them an antiarrhythmic medication like amiodarone. And we'll discuss kind of our persistent VFib protocol. But let's say you get on scene and you put your pads on, you start CPR, and they're in PEA. Cool. We're going to put an IO in. We're going to go ahead and push one round of epi. Our next pulse check, they're in VFib. We're going to shock them. We're going to go back to starting CPR, and then we're going to push amiodarone instead of what would normally have been epi during that time frame. So it's going to be a little bit of obviously some change to get used to, but in the long run, we're hoping by next year everybody's going to be on the same page and what we're wanting cardiac arrest to be run. We want to cut down our pulse checks from 3 minutes back to 2 minutes. That way we're able to see what rhythm that patient is in, and if needed, shock them a lot earlier. And then we really are stressing Lucas shall be applied after the 10-minute mark. Again, everything we're doing in cardiac arrest is try to limit the time off the chest. So if you have a patient who is in VFib or VTAC, we know that there is a potential that we are able to get that person back. And the Lucas is a great device for doing consistent CPR, but what we know is that patients can take a minute to 2 minutes for the Lucas to be applied. And in the moment, you're not realizing that it's taking that long. And 1 to 2 minutes off the chest is a significant amount of time and could lead to that patient potentially dying because we've lost that window of continuous CPR with minimal delay. So really in this first 10 minutes, we want to just concentrate on the things that matter, which is high quality CPR, early defibrillation, early IO access, BLS airway, and pushing the appropriate medication. We can do all that within a 10-minute mark and we don't have any changes in the patient status, and we can start working on placing the Lucas. And when we do place the Lucas, we want to place it with minimal delay in CPR. Please pre-charge your monitors before every pulse check. Again, this is something that saves time off the chest. And think about switching your compressors every minute. If you have somebody who is able to do high quality CPR for 2 minutes, great. If you have somebody who's getting tired after a minute, it's going to be more beneficial for the patient for you to have somebody lined up and ready to go to switch out with that person so that we're able to try to maintain that high quality CPR for that full 2 minutes. All right, so we added a persistent VFib protocol. We had a couple cases this year where we had patients who were persistently in VFib, and we just wanted to create a guideline to kind of help you guys have a clear understanding of what we want. So you show up on scene, you start CPR, you place your pads on the patient, anterior posterior approach. You pre-charge your monitor. Everybody has a hand on a pulse. You stop CPR, confirm they're in VFib. You shock it, start CPR right away. You as the medic should then be prioritizing early IO access. The first medication that you should be pushing is amiodarone. Obviously, during this time period, delegate to somebody to get a BLS airway established, like a IGEL. Next pulse check comes up after 2 minutes. You pre-charge your monitor, hands on a pulse, confirm they're in VFib, stop CPR, confirm they're in VFib. Now you're going to shock them and then give them 150 milligrams of amio during that next round. 2 minutes goes by, patient's still in VFib again. You shock them, and now you're going to give 2 grams of magnesium because low levels of magnesium have shown to put the patient at risk for being in persistent VFib or VTAC. The supervisor then during this time period should delegate to somebody to go get their monitor from their unit. Once their monitor gets on scene, we should go ahead and pull their pads out, put the pads like we normally have done them, which is top of the right side of the chest and then lower left. Okay, so we're going to be set up to do a dual sequential shock, meaning that we're going to charge both monitors during the next pulse check. If the patient is in VFib or VTAC again, both monitors are then going to shock the patient at one time. You're going to continue to do this as many times as needed, and our goal is to hopefully break this patient out of that persistent VFib or VTAC rhythm. We're going to be going over some research studies that kind of support all of these changes. So just to kind of clarify what I said towards the end of the last slide, yes, we will be doing dual sequential as many times as needed, but we're not stack shocking, meaning that we shock them, see what rhythm they're in, shock them, see what rhythm in, shock them. We'll still be doing CPR like we normally would be for 2 minutes in between each shock. So I just need to clarify that doesn't get misinterpreted as we're just going to continue to shock them without doing CPR in between. So if your patient starts off in VFib, do how you normally would have done things. Just instead of pushing epi, give them amiodarone. If they go into asystole or PEA the next couple rounds and they're in a non-shockable rhythm, you'll give them epi like you normally would have done, and you'll continue to give them epi every 6 minutes. So nothing really changes with the non-shockable rhythm part. The only thing that will change is how many times you're doing pulse checks. So again, these are changes that are going to take time. If you happen to forget to do exactly what's written, that's fine. We know that people want to resort back to how they were previously changed. So it'll just take a lot of feedback from training division, and then hopefully supervisors doing debriefs over cardiac arrest calls after they happen to kind of talk about maybe some things that we could have done a little bit better to try to do our best to model what Dr. Stevens wants us to do. So awake CPR. Awake CPR is essentially you're doing compressions, and while you're doing compressions, you're establishing enough blood flow to the brain that maybe the patient starts showing having some purposeful movements. When you stop compressions, they're back in cardiac arrest. So we had 2 cases this year. One was in persistent VFib and was moving around so much to the point that we had to have extra providers on scene hold the patient to the stretcher. And every time we stopped CPR, he was back in VFib and we were shocking him again. The biggest issue with that first case was that we weren't able to effectively provide high quality CPR because the amount of movement that the patient was having. The second case, the patient has some purposeful movements, but it didn't disrupt CPR. So if we went back in time and the patient in the first case, what we probably should have done is call Dr. Stevens very early on, and this is what's going to be written in our protocol to give you guys guidance, is that if you're unsure what to do with somebody who's awake while you're doing CPR, call Stevens. He'll be able to give you guidance based off of what you're telling him or what he's seeing. If there is somebody like a supervisor wearing a body camera that he can live feed in, and based off of that guidance, it could be, hey, go ahead and give this patient rocuronium. That way he stops moving while you're doing compressions, or maybe something along the nature of, let's do a shock dose of ketamine to kind of give that person a little bit of pain sedation so that we can provide adequate CPR. So this section will be in the persistent VFib protocol. It will be at the bottom in the notes section that you guys can read over to give yourself some guidance on what to do in these when you're encountered with these patients. We're going to talk a little bit about the research that kind of supports these changes. Dr. Antevi is a great follow on social media. He's obviously a great medical director, but he's very good at posting the latest and greatest research. He based a lot of the changes that we are making in our cardiac arrest protocol off of the research that I'm going to highlight right now. He's been doing a lot of these changes as far as not giving epi and shockable rhythms, dual sequential, and anterior posterior pad placement for a couple years now, and he's had good results from it. So the study initially came out of Canada. They evaluated dual sequential defibrillation and vector change defibrillation, meaning anterior posterior pad placement, and compared that to standard defibrillation when it came to those patients who are in refractory VFib. The trial ended up getting cut short due to COVID, but they had a decent amount of patients that were enrolled in this actual study, 405 patients. These calls are very rare, so to get a decent sized patient population is going to take a very long time. And even though it isn't in the thousands, 405 patients is a pretty decent number. And you can kind of see in the last sentence how many patients, the percentage wise, how many people got standard defibrillation, how many people got vector change, and how many people got dual sequential. So some of the research results from this show and highlight why dual sequential defibrillation and anterior posterior pad placement is going to be the way that we're trying to go when it comes to patients who are either in shockable rhythms or in persistent VFib or VTAC. In every single category, those ways of defibrillating patients were better than the standard group. You had higher success rates of termination of VFib. You had ROS that occurred better. You had survival with neurological outcomes better than the standard group. So this is just kind of highlighting and giving you guys a brief understanding of why we've made these changes, and the way we're making these changes are based off of the latest research. So we're going to talk about nitro pace for a little bit. The indications and contraindications for nitro are going to be exactly the same. This is going to be great for your patients who are fluid overloaded on CPAP or BiPAP, where you don't want to have to break the seal every single time to give them a sublingual nitro. So initially, you're going to want to start off with at least one sublingual nitro, because that's going to work a lot quicker than your paste. The benefit of the paste is that it was going to last a lot longer than what your sublingual nitro will. Normally with sublingual nitro, you're having to do it every 5 minutes. This is going to last for 10 to 12 hours. So there's going to be a nice continuous therapeutic effect of the medication. Ideally, you want to place this about 1.5 inches to the left upper chest wall, and you want to try to do it in an area where there's not a lot of hair. So if it's going to be a very hairy patient, you may consider shaving off the chest so that you can apply your nitro paste. It's going to be about 0.4 milligrams per patch, which is very similar to what you're already giving the patient sublingual. So our frontline medication for seizures is Versed. Previously in our old protocols, we had a max dose of 10. We upped the max dose of 15, still given in increments of 5. If they're not responding to your Versed, then you need to dispatch the supervisor. There's a chance you may have to RSI. But before we get to the point of RSI, we want the supervisors to get 50 milligrams of ketamine, see if the ketamine actually terminates the seizure. Ketamine works off of a different receptor than a benzo does, and working off a different receptor may be what's needed to actually terminate the seizure completely. And if the seizure is terminated, then reevaluate your ABCs, because there may be a chance you may not need to intubate them. If you do have to intubate them, that's fine. It's just the problem is before we would intubate these patients and they're probably still seizing inside their brain. We just didn't know they were seizing because we paralyzed them and took away the physical movements of the seizure that is normally happening. So at least if we're able to terminate the seizure, but we're having to intubate them still, we're at least now giving the brain a rest to where it's not continually seizing during transport. Treating electrolytes in EMS has always been very tricky. We don't have labs, we can't confirm what we're suspecting, but we really want to develop a protocol to where we're making sure we're taking the patients who are at the highest risk for developing hyperkalemia serious, because if you wait too long and you don't actually aggressively treat this patient could go into cardiac arrest in front of you. So we concentrated on you guys looking at dialysis patients who have missed dialysis, plus they have EKG changes. Now, this population of patients are the more likely reason why we might see somebody in hyperkalemia, but that is not the only reason why. If you have a strong clinical impression that a patient is hyperkalemic based off of your clinical presentation and maybe the EKG you are obtaining, then doc would rather you treat it based off of your clinical impression than not treat it. But at the end of the day, be cautious about what you're doing, because everything that we give somebody is not something that we can necessarily take back. So we really want to try to treat electrolyte imbalances towards the most high-risk population of patients, which is usually your dialysis patients. And the best thing that we can do for them is give them a gram of calcium, because calcium stabilizes the heart. And then albuterol is a safe medication to also give, because it would also decrease the serum potassium that is happening inside their bloodstream and push all that potassium back inside the cells. Peak T waves is usually an early indicator that the patient might have some form of hyperkalemia. Obviously, you need to put the full clinical picture into context, but as the potassium continues to build in the body, that peak T wave will eventually run into your QRS and cause your QRS to widen. And if your QRS continues to widen, it could eventually go into something that's called a sine wave. A sine wave is usually a slow, wide rhythm that typically would look like VTAC, but it isn't at the rate at which VTAC is normally at. If you have a patient who has a history of dialysis, who has a really wide QRS, you should probably think that the patient is probably hyperkalemic and start going down the treatment pathway that we listed out in the previous slide. So here's an example of an EKG in which a patient has developed severe hyperkalemia, in which the peak T waves have now running into the QRS, causing the QRS to widen to a point that the patient is now in a sine wave. So again, very ugly EKG that needs emergent treatment before the patient goes into cardiac arrest. So we're going to be talking about posterior EKGs, when to do them and why to do them. So the big thing is that isolated posterior MIs are not very common, but they are typically missed. And the reason why they are typically missed is because they don't present like normal STEMIs. Normal STEMIs have elevation. In this situation, you're going to have depression in V1 through V3. The reason why you're having depression instead of elevation is because when we're taking an EKG of somebody's heart, we're looking at the anterior side of the heart. Whenever somebody's having a posterior MI, it's happening on the back side of the heart. So what we're typically seeing in an EKG is reciprocal changes of what's happening on the back side of the heart. So if you do have a patient who has chest pain or is presenting with some type of cardiac related complaint, and you take an EKG and you have depression in V1 through V3, the first thing I want you to do is think about, all right, I need to go ahead and get a posterior EKG to rule out that this patient is not having a posterior MI. And the way you would do that is take V4 through V6 and move it to the backside right underneath the left clavicle. And in the next slide, we'll kind of look at a picture to give you guys a visual of what I'm talking about. So here's V7, 8, and 9, which is essentially your V4, 5, and 6 moved to the backside underneath the left scapula. Whenever you print off your EKG, you're going to be looking in the area of V4, 5, and 6 for any signs of elevation. You need elevation in 2 or more boxes. And then write a P at the top of the EKG, so when you're looking back throughout all your 12 leads, you know that that was a posterior EKG that you took. So we're going to talk about the updated chest pain protocol, and it's going to give you guys some guidance on what Dr. Stevens wants as far as what should be ALS and what should be BLS. A lot of this to me is common sense, but there are situations where we've had patients who have been BLS when they needed ALS care. So if you have somebody who has chest pain and it's described as pressure, dullness, aching, tightness, and it radiates to alternate locations, or you have any one of those symptoms, that's somebody that needs continuous cardiac monitoring regardless of what their EKG is showing. If they have any sort of chest pain with, associated symptoms like short of breath, they have some form of dizziness, they have syncope, okay? Or they just are somebody who has some of these complaints along with EKG changes, that's somebody that needs continuous cardiac monitoring. Or if they have a significant cardiac history on top of one of these complaints. So they have some form of chest pain with a prolonged cardiac history, or they've passed out at home and they have a significant cardiac history. They're short of breath with significant cardiac history. Regardless of what their 12 lead is showing, we need you to trend those 12 leads, because remember, EKGs only tell you what's happening in that moment of time. It's not telling you what's happening over time. So you could have somebody with a normal EKG that over time develops ST depression and then ST elevation. But if you only took the 12 lead in your initial patient contact, you're not seeing what's happening over time. So we need EKGs to be trended whenever we have these high-risk cardiac patients. So right-sided EKGs should be done whenever you have elevation in 2 or more leads on the inferior aspect of the heart. And the reason why that is because some patients will have their left coronary artery supplying the right side of the heart, but majority of patients have the right coronary artery supplying the right side of the heart. So we know that patients who are right coronary artery dependent are more likely to be preload sensitive and more likely to develop hypotension whenever you're giving them something like nitro. So a very quick, easy way to do a right-sided EKG is moving V4 over to the right side, right underneath the right nipple, typically where V4 would normally be on the left side. Now, the most accurate way to do right-sided EKG is taking V3 through V6 and flipping it to the opposite side. But V4 is relatively pretty accurate and will give you a lot of information very quickly. So here's an example where you're moving V4 from the left side to the right side of the heart. And again, it's in the area where V4 would normally be just on the opposite side. So you're dispatched to a seizure call. When you arrive on scene, you find that the patient is pregnant. You're being told by the husband that the patient is 36 weeks pregnant. So 1, what is this called? 2, how would you treat it? So 1, this is eclampsia. If they have a history of seizures, I'm still worried about the patient having eclampsia. Either way, if they have a history of seizures or not, a pregnant patient seizing is not a good thing for the baby, because that's more than likely causing some form of fetal hypoxia. And the best way to treat this is start basic first, get an NPA in, do a non-rebreather or assist with BVM ventilations. And we know that the typical treatment for a patient with eclampsia that's having seizures is magnesium. But when a patient is seizing, you can't always get an IV. And what if they have really poor vasculature? So the best thing that you can do in this situation is treat them like you normally would, give them 5 milligrams of Versed to stop the seizure, where it's intramuscular or intranasal. But you're giving a one-time dose of Versed. If they're continually seizing after your one-time dose of Versed, you need to call Dr. Stevens so that he can give you some guidance. But if that one-time dose of Versed is able to break the seizure, the next thing we need you to do is get an IV and give that 5 grams over 20 minutes to ensure that the patient does not go back into having another seizure. So this was something new. The magnesium was not new, but the Versed being added in for eclampsia is new. So that's all I have today. Again, please go in the protocol app and actually look at the change log for all the recent updates, because I did not cover everything. I really want you guys to not be afraid to speak up, ask questions. If you need to train over anything, please let me know. At the end of the day, we're doing our best to give you all the training we can so that you can go out there and use these guidelines to better take care of patients. So it's up to you to utilize the resources that you have available at this department to make yourself a better paramedic or EMT.